Good day, global citizens. Welcome to another episode of Dr. Fajembola's Opinion. On today's episode, I have a senior colleague, a professor, who I'm so glad he honored my invite to discuss a very delicate topic, which is very rare for people to read about and also to discuss. So I'm very happy we have an expert on board today to discuss and also teach us in ways layman people outside science can understand. To join me to welcome Professor Seye Abimbola. Professor Seye, how are you doing today?
Thank you very much, Azeezat. Thanks for having me. It's great to be on your show.
Thank you so much for being on my platform. Sincerely, for those who are not Nigerians, let me put it this way: Professor Abimbola is on Dr. Fajembola's Opinion. So for those who are not Nigerians, we are not related. Because I know the Abimbola Fajembola, they might get them confused. Is entirely a different person who is also from the southwestern part of Nigeria, where I also come from. Let's get to know the guest researcher for today. Professor Abimbola was born and raised in Nigeria. He's a professor at the University of Sydney in Australia. He has lectured, researched, and written extensively on learning and governance in health systems, and on knowledge practices and epistemic injustice in global health. He was awarded the Prince Claus Chair in Equity and Development at Utrecht University in the Netherlands in 2020, and was the Radulovacki Visiting Scholar at Northwestern University in the United States in 2024. His research on dignity-based practice in global health research is currently supported by a Discovery Award from the Australian Research Council. He was the founding editor-in-chief of BMJ Global Health 2014 to 2024. His essay collection titled The Foreign Gaze was published in 2024. Thank you so much, Professor, for that beautiful summary of your biography. Actually, I knew Professor Abimbola from his discussions on global health on Twitter. And if you use social media a lot and you're in the global health space, you must know Professor Abimbola. You must, in quotes, you must know Professor Abimbola is a loud voice in global health. So, Professor Abimbola, today we are discussing the adoption and scale-up of the cardiovascular polypill, a realist institutional analysis. Actually, before discussing this paper, before we are bringing this paper on board, I didn't actually know about the cardiovascular polypill. Let me put it that way. I have to be frank with you. But going on Twitter, because normally I get tweets on the cardiovascular polypill, there's actually a lot of discussions. People are really discussing this on social media. So I try to mix, because we're talking about innovation in the field of medicine, I try to mix tweets, what people are saying regarding polypill and also other innovations in medicine. So the first tweet I got is from a Dr. Enrico Ferro, where he said, "Thank you for covering our World Acted Fed roadmap on the CVD polypill. Despite better efficacy and cost effectiveness, this technology is not being adopted. A multi-stakeholder collaboration is needed to align on the vision and improve outcomes," which I feel is right based on what I've read on the paper. The second is on, because we're in the season of Nobel Prize, so I try to bring in some Nobel Prize tweets too with regards to medicine. It's from Dr. Michael Taiwo, who is also one of the loud voices on X. Another Nobel Prize just went to Susumu Kitagawa, Richard Robson, and Omar M. Yagi for their development of a new form of molecular architecture called metal organic frameworks. Technology that can harvest water from desert air, capture carbon dioxide, store toxic gases, or catalyze chemical reactions. They already tested it in California Mojave Desert, where they pulled drinking water from the desert air. Science keeps rewriting what's possible. We all agree science is evolving and innovation is most needed in this century. The last tweet is from Neto. He's also a medical doctor. He said someone asked recently whether medicine is really as hard as it's made out to be and whether the material could be condensed. I should have pointed him to the increasing complexity in the subject matter of Nobel Prize winners. We've gone from simply discovering insulin to understanding the complex intricacies of immune tolerance and opening up all new fields. Since I qualified, new technologies like mRNA vaccines, CSRSPR, innovative immunology, immunotherapy, and more have come in, and medics are required to have a decent understanding of most of them. AI will help, but the basic underlying material must always be understood. The sheer volume and complexity of what it is, of it is what makes medicine hard. So medicine keeps evolving, and we can see that from the intricacies in innovation needed in this age. Professor, first of all, let's see it. Let's take it, because this paper, it's a paper that you have to read, reread, and reread. For me, I had to reread, keep rereading to really understand it and be able to break it down for our audience. Prof, what is a polypill?
Thank you very much, and thanks for that introduction, especially on innovation and the advancing complexity of medical science, and I would even add health science. The polypill, it's a strange thing when a word like polypill is appropriated by cardiovascular people. I mean, it's a concept that is much broader than cardiovascular. There have been other polypills, in other words, drugs that are essentially a combination of several other drugs put into one package for ease of administration and, as it were, compliance, quote and unquote, with the dosage. It's been used in tuberculosis. It's been used for HIV, where several drugs are combined into one. And it makes sense to do the same for cardiovascular disease prevention, right? Where people who are at high risk tend to be prescribed a battery of medication that they often take throughout the day, multiple tablets. And the logic of the cardiovascular polypill is, can we find a way to make all of that into one tablet to be taken once a day? So conceptually, it makes absolute sense that this is going to work. I mean, who wouldn't want that, right? It makes too much sense. And that's the logic. Basically, it has antihypertensive in it. It has anti blood lipid reduction medication in it. It has platelets, which helps to reduce platelet dysfunction, which is aspirin, low dose aspirin in it, etc. So the regular, usual things. And often people take more than one antihypertensive, right? So it's multiple things in one formulation. So that's the logic. The logic is that it reduces the burden, the pill burden, as it were. And it makes sense. And even though it makes sense, and I keep saying it makes sense because I think I need people to really get that it makes sense, it hasn't been scaled up broadly. And that, for me, is interesting. That why is something that makes so much sense not working at scale? And that was the primary motivation for doing this paper.
Thank you so much, Prof, for that. Thank you for enlightening us that, yeah, Polypill makes sense, but also it's easy life. And when something comes easy like that, we are open, it's accepted. Because even though it comes easy, there are many ants involved from production to dissemination. So, Professor, can we say Polypill is a form of drug synergism?
No, so synergism is um, when the whole is greater than the sum of its parts, right? So when the drugs themselves are working in a way that they multiply each other's effects, right? And that's not the goal here. The goal with the polypill is even simpler. It's simpler in that this is not trying to make the drugs work better, as it were, pharmacologically, right? It's not trying to make the drugs do more than they would otherwise do, right? It's just trying to get the drugs into the system in an easier way, get people to use it more conveniently, as it were. So it's not an example of synergism. Synergism would be drug A, drug B, it's equal to, is greater than A plus B, right? Yeah.
Exactly.
Yeah.
Thank you so much for shedding more light on that, Professor. From the paper, now let's dive deeper into the paper. Without concentrating on the polypill, who are researcher entrepreneurs? Are there famous names who have the stack?
I often say to my PhD students that every research paper is an exercise in persuasion, right? So every piece of research you're writing, you're trying to convince some people of something, right? That something could be the value and the merits of what you are analyzing, or it could be your own brilliance that you're trying to convince them of, or it could be your own fair-mindedness that you're trying to convince them of. But there's always something you're always trying to do. I hope people are always trying to do something, because I am always trying to do something when you write a piece of paper. And if then your work is to make a discovery of something that is useful to people, or evaluate such a thing, whether it's a drug or whether it's a big complex thing like, say, a community health worker program, or a big complex thing like how you reorganize the governance of a thing, of a place. Go from as simple as a drug to a digital technology to a social innovation, right? If your job is to work on those kind of things, then of course part of your responsibility, I would assume, is to try to find a way to get people to use it. Right? And the first step in that process is first demonstrating the value of the thing, right? And the evidence that the thing works, or the logic of its working. And I'll return to why I am sort of splitting the idea of the evidence that it works and the logic that it works. Right? But your job is to move that along, is to push that along. Then when you are doing that as a researcher, you have been an entrepreneur, right? Because when you look at the system, and this is what an entrepreneur does, you look at the system and you say, what is the opportunity that I can leverage here? Often a business person is leveraging it for profit, but you may be leveraging it for social good. I say, where are the gaps here that I can make the most of to advance social good, equity, justice, improved health, etc. Then, if you're a researcher, like researchers involved in the Polypill, and you're looking at, oh, this is a great thing, it makes sense, I want people to use it. How do I make that happen, right? Like, so every researcher who does that, whether or not they believe they are entrepreneurs, right? Because they are doing that. And again, you can think of almost any innovation that has made it to market and scaled. Every researcher behind those is a researcher entrepreneur. I often call them policy entrepreneurs, because again, often okay, let me make another distinction. There are things that are so market viable that you may not need to touch the policy system much, if at all. That all you need to do is to get it into the market, and it would ride, right? I don't think the person who made iPhones needed to do too much policy advocacy, although they've had to do policy advocacy down the line for other reasons. But iPhones sold themselves, right? Many other innovations sell themselves. Many other drugs, most drugs sell themselves, right? But the Polypill is peculiar, which meant that it didn't need just business entrepreneurs. It also needed policy entrepreneurs, because you had to find ways to tweak the policy levers to allow that thing to ride the market wave. So again, that's the nature of the task of the role that I described as policy entrepreneur or research entrepreneur.
Okay, thank you so much. Can our audience see every researcher is a research entrepreneur in making?
Would hope. I would hope. Again, let me say this slightly differently. The entrepreneurship doesn't have to be about money, right?
Okay.
The point here is that you're trying to change something. You're trying to understand the levers in a system that allow you to make a change happen, and almost get a change to drive itself. Once you can arrange the levers properly, it just goes in and just drives itself, right? That's the goal. I would be surprised if any health policy, health systems, public health, even medical researcher is not thinking like this. Because even if you have you're in a hospital, like I'm just thinking of the most, not even public health. Hospital, you do a study, you realize that there's a procedure that is increasing the rate of infection, right? Post-operatively, right? It's a procedure, and you want to change it. And you know that the people who do that procedure believe it's great and it's the best thing, right? It's what we've been taught, so that's all they know. Now, you have to find a way to change their mind. And you and I know that evidence is not always enough, right? We believe that we love evidence, we are researchers. But evidence is always often not enough. So you have to find a way to look at the system and say, how can I change this practice? And when I'm thinking like this, and I hope others are thinking that way too, is, okay, is there a way that I can introduce something into this practice that just changes these people's practice without them even thinking they are changing their practice? In other words, can I treat them? I'm thinking that, like, can I treat them? Because I know that they would likely say, no, we are cool, we are the great surgeons, we know what we're doing. Or they may say, well, on balance, this makes sense. So anyway, could I put in a technology that will change their mind? So that will change their practice without them changing their mind? Or can I put in an incentive, something that makes them want to change their mind because they gain something from it? Or can I get the hospital administration to insist that they change their mind? In other words, can I use force? And again, my job as a researcher who has found out that is to work out how to make that change happen. And in doing that, I'm behaving like an entrepreneur. See, I'm thinking about the levers in the system and what can I pull? What is wise to pull? What should be my option C? Where should I start? That kind of thing. Right? That's how I wish we all thought about research.
Thank you so much, Prof, for shedding more light on that. That which research entrepreneurship is about creating positive change in our world. Money being a bonus. I know some people when they hear entrepreneur, money is involved, researchers are making money. So thank you so much for that. Would like to know from the paper, you and your co-author said in the 20 years since the idea was bettered, the polypill is yet to be widely adopted and scaled up. What challenges, and I know you mentioned it at the beginning, that it's a good idea. Why is it not being scaled up? What challenges are present in adoption and scale up in the global north from the global south?
So my co-author, Huming Liu, has been involved for many years, I think, certainly more than 10 years when we did the study, in the process evaluation of trials of cardiovascular polypill. So she's been very deeply, intimately involved in this process. And I, for almost all the 20 years of its life, I've been a watcher of it. Because I saw the early, I think I was still a medical student, or just after medical school. I saw the early editorials in the BMJ about the Polypill, that this new thing has come, it's going to change everything. It's slightly in the early 2000s. So I've been closely watching this thing, and I worked at the research institute that has been the biggest champion of the Polypill. I did my master's based there. I did my PhD partly based there. So I know the actors, and I've observed them. I shouldn't say more than that now, but I know the actors. And if you read the first paper announcing the idea of the Polypill, by Law and World, they compared it to putting something in the water supply. In other words, the first modeling exercise that sort of suggested that this was a great idea was the modeling made the assumption that everyone above the age of 55 would take this. Like everyone above the age of 55 took this, it would bring down the rate of cardiovascular disease and strokes, etc. I think about 80%. It was a high number, right? So the modeling was promising. And the trials subsequently sort of showed that, well, you brought it down by about 40%. But 40% is a lot. So again, this is really an effective thing. But one of the problems, one of the reasons why there have been resistance to it, I think, is partly the resistance that we have and should have to suggestions that everybody takes something. So there's that resistance. And again, remember, for something like the Polypill, you want to convince the clinicians who will prescribe. Right?
Exactly.
And clinicians are human beings too. And they read these papers and they think, I would rather be in control of what my patients take rather than this blanket, everybody takes the same thing kind of logic. Right? So I suspect, and the paper suggests that a challenge that it has is that basic admirable human tendency to reject things that are not differentiated and are almost imposed by force or by trick, that everybody takes it. So there's that. Which means many clinicians, and again, when I say clinicians here, I'm thinking people in the global north, right? Another important challenge that it's had is that in its conception, it was conceived as a polypill of pills that are generic. Generics meaning that pills that have been produced at low cost. So copy versions of expensive patented drugs, typically produced in India. And people often say India is the pharmacy of the world. That's just how big the production system is. The challenge with that is that in the pharmaceutical market, there is the market for really expensive drugs that few people take but pay a lot of money for. Right? Now if you are a pharmaceutical company, that's the game you want to be playing, right? 5,000 people have this thing, and each person pays $100,000 for one. You don't have to build a big manufacturing plant, right? It's just small, right? You have your market, it's not too big. Your advertising cost is not too big. Yeah. They're paying high amount of money for it. That is the game you want to be in.
Exactly.
Yeah. No. The other extreme is the generics market, where the game is we produce huge amounts for little money because people are paying low amount of money for each one. So it's not like the profit margin is small. So you need volume to make profit, right?
Exactly.
So you're playing between those two extremes, and those are the extremes where most of the market is. One extreme, small, huge profit margin. Another extreme, huge, low profit margin. The challenge with the Polypill is that it's trying to be somewhere in the middle, which is that you bring a number of generics together. You add a bit of value in putting them together in one package, etc., and then selling them. Now, it is not the market that generics companies understand and play. That's not their game. It is also not the market that rich companies, in fact, if anything, rich companies are not very happy with you because you likely eat out of their market, right? So you're in this precarious middle position, which is one of the reasons why it's hard. Now, it is also designed for poor people, groups, countries, right? So this, again, noting that in the high end, rich countries cover their population, rich countries that are responsible. The United States doesn't cover enough. The rich country that doesn't cover too much. But most rich countries pay for their people, or their people are rich enough to pay for it. So there's no need for them to care too much about this new thing.
Mm-hmm.
Countries that are not very rich buy a lot from India. But they will benefit a lot from this Polypill, right? If you were to get to market. But they don't control all the levers of finance and the economy and the pharmaceutical industry. So that the Polypill has struggled to have takers, right? That anyone who's going to invest in it will be doing so almost as a social enterprise. And then on top of that, he ran into a lot of trouble, now resolved, thankfully, of making the combination work chemically, right? That there were aspects of there are some drugs in the formulation that were, that their bioavailability was reducing within the combination. Of course, there was some reactions or something like that. So it also technically difficult to formulate. So that even though there were generic companies that were willing to take it up, they saw that they were spending too much money trying to make it work. So they were often dropping off. Like, oh, I can go and do my mass market deal. Why am I struggling with this thing? So there were those who tried. But again, I know that some other smaller companies are sticking with it now. So there are all of these reasons, right? There are also clinicians, of course, who were reluctant, as I mentioned earlier, to prescribe this thing, thinking that it will reduce their ability to titrate. Because again, many doctors were trained to titrate treatment for high blood pressure, etc., over time, and to work out which combination and dosages work for a particular patient. Right? So there's a reluctance to give Polypill that sort of removes that ability from you as a clinician. So again, it's required a lot of re-education, almost efforts at re-education, doing sessions, doing seminars, trying to influence what gets written in textbooks to change that setting. So you see how there are just too many like demons on the path of this thing called Polypill, trying to make it not work.
Exactly.
Yeah.
Thank you so much, Prof, for explaining the politics around the adoption and scale-up of cardiovascular Polypill. We would like to know, artificial intelligence is rocketing. And I know I discussed it in one of the tweets, artificial intelligence and innovation, with regards to health sector innovations. Do you feel we are innovating enough to meet effective patient management in the 21st century?
I live in Australia, and I grew up in Nigeria, and I think that's a very important statement before I answer this question. which means that I trained in medicine and I experienced life as a human being and as a junior doctor in a place where things were significantly just less sophisticated clinically.
Exactly.
And where access was significantly constrained by socioeconomic status, by people being able to pay and being proximate enough to places where they could receive care. And live in Australia where, frankly, almost everyone has access to really, really high quality health services. And it's hard for me. I'm pleading with you to understand why, with this question, my bias is to say we are doing great with patient care in a rich country. We're doing great. And the truth is that there's only so much further you can push in a place where things are highly optimized. So much further you can push clinically, right? Actually, right? Socially, it's a different problem. And when I say socially, I mean how a government or a country organizes care so that most people, if not everyone, has access, right? That's a social problem. But I'm talking about the clinical technological space. Like we are pushing the edge of what is possible. I know as human beings, thankfully, we don't rest, so we'll keep pushing. But it's not much marginal value we would get for how much we push. And I feel like the space where we ought to be thinking a lot more about innovating and pushing is the space of access, one, but also in the space of prevention. And those are spaces where I think we have a long way to go. And when I say prevention, the first thing I'm talking about or thinking about is poverty or socioeconomic status everywhere, including here in Sydney, Australia, where I live. If you look at the chart of life expectancy of health outcomes, you still see a very sharp distinction between wealth quintiles. It's there. The lowest is still bad, right? Relative to the highest. It's clear across almost every health index, right? And you find the same thing almost everywhere in the world, right? And I feel like, I don't know what AI can do for us there. I doubt it can do much. But I feel like that is, if there's a place where we need to be thinking a lot more about effective management, quote unquote, of health and well-being, that would be it. Like we need social innovation that reduces poverty and that flattens out, or as the former UK Prime Minister Boris Johnson, whom I otherwise can't stand, used to say, level up, level up that difference, bring the health outcomes of people who are in the lower socioeconomic group to be as high. That is when I would feel we've done our job. That's the business I'm trying to be in.
Thank you so much, Prof, for that elaborative response. Please, can you shed more light on the non-adoption, abandonment, scale-up, spread, and sustainability framework?
There's something called survivorship bias, which is this thing where you look at a place and you assume that the sample of people who are doing well is the entire sample there is, because they are the ones who are present, because others are not doing well, have died or left the game. So you look at the place and you go, people are doing really well. This survivorship bias. And I feel like we do the same thing with innovation, right? Where when we look at innovations, we only look at the ones that have been successful. And we think, this is so, innovations are successful. Look, innovations. Whereas most innovations never make it to that game at all, to the place where you get to see them. They're never there. And which means, to my mind, that we don't learn enough from failure. Right? Because if all you ever look at, or if all you ever sample, if all that's in your face, are those ones that have been successful, that have been adopted and scaled up, then it's hard for you to really understand why those that have not been successful have not been successful. There's a very beautiful line, the opening paragraph in this novel called Anna Karenina by Leo Tolstoy, Russian writer. I will likely not get every word right, but something to the effect that all happy families are alike. Every unhappy family is unhappy in its own way. Right? Now, if you look at all the innovations that have been successful, they are alike. Like, of course, you do this, you do this, you do this, you do that. It feels like it feels simple and easy and destined to be so. But when you look at the broader sample of the ones that have failed, you start to see that each one is failing for peculiar reasons. And if your job is to try to move an innovation to adoption and scale up that do not have the properties of the ones that are successful, you need to be able to look at the ones that are not successful to learn from them. Such that, so we need to study, as this framework is, non-adoption, abandonment, non-scale up, non-spread, non-sustainability, right? We need to study those things if we are going to learn how to make innovations work, right? We need to study the negative, right? Or at least we look at the positive, the apparently positive, from the perspective of not working. So that's the spirit of that framework. It was developed by someone who was my senior colleague, whom I worked with during my postdoc at Oxford, Trish Greenhall. And then we did a paper together on it, just examining how theories can be used to explain each domain of things necessary for adoption and scale up, how to think about what's playing out in each of them. In each domain, whether it's the nature of the innovation itself, or the nature of the system that should take it, or the nature of the people trying to push it, or the etc., or its value proposition, all of those things. So anyway, that's the spirit of that framework to try and help understand how and why an innovation may not be adopted, scaled up, or may be abandoned, etc.
Thank you so much for simplifying the NAS framework. The non-technological innovations receive from the paper, non-technological innovations receive less conceptual attention, therefore limiting the extent to which insights on their adoption and scale-up can accumulate. Prof, do you feel as a generation we are downplaying non-technological innovations in health? As effect, and non-technological innovations in health, and it has effect on the advancement of medicine?
Not just as a generation. This is the story of public health. But that's a different story. But this is the story of public health, that we've always downplayed non-technological innovation. If you read any history of public health worth reading, a strand through the history will be how we've deliberately looked to technological solutions and innovations and looked away from social and structural ones. It's a story of public health. It's not new. And that was partly what I was pointing at when I was describing how in terms of what we need to prolong healthy life, we have most of the technology, and a lot of additional lives, time, etc., we may get will be expensive for the marginal, benefit. It will be expensive. We know already that in rich countries, a large chunk of health budget is spent in the last 6 months of life. Right? And it's like not of life when people are really old, right? And I'm not saying we should discount the lives of older people. I'm just describing the pattern of spending, right? It's expensive to prolong life a little bit, right? Much more expensive than it is to make people whose life expectancy now is in 40s, 50s, 60s, early 70s, push it further. So again, that we are almost optimized to choose rich, highly expensive for few people spending versus basic spending to often, which will be prevention, right? To move people's life expectancy significantly up. It's a social / political choice that we've often made. At the beginning, early in the history of public health, especially the English in England version of the history of public health, it came about because of the very visible consequences that the Industrial Revolution had for the health of people who were workers and who were poor. It was just very clear. It's always been there, but it was much clearer and much more rapid, accelerated, and visible. So it generated a lot of pushback and campaign and protest, etc. That first the employers had to do something about it, the government had to do something about it. And instead of working on the social conditions that put those people in a position where they would work in the way they were working, and be remunerated in the way they were remunerated, what won the day was building sanitation, which at the time was technology, right? Remember, now it looks, but it used to be the fanciest thing, like technology. Do sanitation, do a few things that will be technological but not social, right? And that has been how we've played this game. So that's part of the reflection in that part of the paper, that if you look at the literature, including the literature review and case studies that were used to develop the NAS framework, there was a strong bias for the technological. And I was thinking there that we need to find a better way of thinking about innovation that does not default to the technology.
Okay, thank you so much, Prof, for that answer. I believe our audience are flowing and following the discussion. Professor, what are three stakeholders? What three stakeholders are key players in adoption and scale-up of health system innovations?
But there are different ways to think about stakeholders. In the paper, in this, I call it the Polypill paper. In this paper, there's a framework that we used that had 4 levels: L1, L2, L3, L4.
Okay.
And L1 was what I was describing earlier when I said that there are ways in which societies function and people behave that are informal. They're not official rules. There are no rules to say be suspicious of things that are put in your water system. Right? There's no rule like that. But we are, for various reasons. Could be something that happened in the past, could be stories that we've heard, could be things that we've seen, could just be how we are wired to think and behave. So there are those things, right? And that's the L1. And they don't change easily, right? And the framework sort of said it changes in the 100 to 1,000 years, except maybe there's a war or a pandemic or something that is really a huge shock, could really shake people off a certain set of social assumptions and formations, right? So the things that often are available to be played around with are the L2, L3, L4, right? And L2 basically are formal rules, policies, government, the way governments work, the assumptions that are carried within policies. Are we capitalists? If we are capitalists, is it our preferences to sit back and let the market decide? Do we believe that we intervene in the market? And if we believe that, what do policies look like? Is that those kind of L2, like constitutional, but also how governments function, which, in that framework, it says it changes between say 10 to 100 years, right? It changes, but not really quickly. And often, if you are a policy entrepreneur and you want to make a change happen, sometimes you can do stuff there, but you really have to know what you're doing and be willing to play the long game. And there are policy entrepreneurs who have played the long game and won, right? Anyway, so there's that L2. And there's L3, which is a broad range of entities that we may describe as organizations. Could be a lobby group, could be even businesses and their board of governors, could be and shareholders, I should say, could be professional organizations like groups of doctors, groups of cardiologists, what the training and teaching is like, how they are optimized to function, what the assumptions are, what the understanding is, whether it is we believe in evidence, full stop, or we know that there are other things to think about. So that level of L3 thinking. And there's L4, which is just market forces. Right? You bring something to the market, I like it, you price it well, I pay for it, I'm fine. Right? You bring something to the market, it's too expensive. I go to L3, to my insurer, and say, can you cover it? Right? And then they decide to cover it, and then I can buy it. So it's this kind of. And then the insurer, of course, also functions within rules that are made by L2, which is by government policy, right? So there are all these levels that it'd be easier to move around, right? And it's the actors at each of those levels, the actors setting the price, the actors who are able to afford or not, L4, the actors who can decide to cover or not cover payments, who can decide whether it's prescribed at L4 or not, etc. That's L3. And then the actors at L2 that sort of create the broad policy architecture, right? That's how we think about three sets of actors who play a big role in whether innovation is adopted or scaled up or successful or not.
Thank you so much, Prof, for that. Thank you so much for revealing the stakeholders involved in the Polypill adoption and scale-up. Professor, moving forward, what factors influence the adoption and scale-up of innovations? Especially in this case now, the cardiovascular polypill.
Like I've described earlier, so there's those 4 levels, and there's the story of the polypill that I've also described. A message that I was hoping the paper would convey, and I'm not sure we were successful at conveying it, but we certainly tried, is that this is an unfolding story. This is not the end of the story.
Actually, I got that from the paper.
Yeah, thank you. I'm glad that this is not the end of the story. This story continues to play out, and it's still playing out. I know, for example, that a few weeks ago, the polypill was listed. So a couple of polypills were listed in the WHO essential medicines list, right? Which is a huge win, and you would have seen in the paper that there were efforts to make that happen, and it was difficult to achieve. Which is a huge win, which means that in part some governments that pay for drugs on the essential medicines list will pay for them. And if only 5, 6, 7 governments do that, it's already a win. Because sort of leaning into something that likely have a cascading effect, right? So when you're talking about, especially about the political factors that may be consequential, being on the essential medicines list of the WHO is one. Now, things that are on that essential medicines list often are covered by insurance within the countries that adopt that list, right? Which also means that the accessibility may be increased or improved significantly in the places where and I'm thinking here of middle-income countries for the most part. Middle-income countries tend to adopt the medicines list and often are able to pay for a good chunk of it through their national insurance schemes or the private insurance schemes that the government sets the rules for, right? So that I expect to work a bit in that way. I know that more and more clinicians are knowing about the Polypill, are being taught about the Polypill, are being socialized into seeing that it is not, it's not this boogeyman that they might have been. I've seen it as it's often a really good thing, and there was also something that one of the interviewees in the paper said that I've kept thinking about, which is that there was an assumption by the people who were trying to push the Polypill, that you needed to establish evidence for its effectiveness as a Polypill. And the person, this interview was saying, in a rich country, this interview lives and works as a cardiologist in a rich country, said, what if we didn't think of the Polypill as a pill, but instead full stop as a prescription strategy, right? So that you prescribe, and then the patient takes it to the pharmacy makes the Polypill. Now, again, there are places in the world where you can make that in a pharmacy, right, on order, right? Which cuts a lot of the challenges of the Polypill get resolved in just that way of thinking about it, right? Which is one a clinician still has control because he can actually prescribe a specific formulation, right? That all of that legacy sentiment that someone is forcing this on everybody disappears. In other words, that way of thinking about it can change what it is about. Acknowledging, of course, that you won't be able to do that in many countries, right? There are not many countries where the pharmacy retail system is able to do that. But again, I know that there will be people who are doing that version of it, right? Which again solves a lot of the problems that are obstacles on the path of the Polypill. And the logic of that, the reason why I was saying that is that your assumption about what the innovation really is could really shape whether it's adopted or scaled, right? The assumption of the people pushing it. Like, what is the innovation here? What is on your mind? What do you think is really going on here? And if you think it's a drug, you approach it differently than if you think it's a prescription strategy, right? Or a pharmaceutical formulation strategy. So again, just putting another layer on the idea of the factors that may promote or obstruct the adoption and scale-up of the Polypill.
Thanks so much, Prof, for elaborating on that. This words, they kept repeating in the paper. They were repeated consecutively in the paper. They evade, exit, alter, abide. What is unique about them? I know you mentioned the levels, but what is unique about them?
As you may know, I don't personally care about the Polypill very much. It's not my field. I don't think about cardiovascular things. So the scientific motivation for this paper was to do something I've often wished people would do a lot more, which is to turn the lens on researchers themselves, or on research entrepreneurs, on researchers who stop, as I described. We should all be research entrepreneurs, and try to analyze how we behave Because typically when we are thinking about the adoption and scale-up of innovations, we focus on quote unquote this system, or we focus on patients, or we focus on other people, not us, because we are the ones doing the analysis. So we don't analyze ourselves and ask ourselves, okay, so why did you do this at this time? Why did you not do that? How did you change your mind? What informed your decision about this, etc. Right? And it's partly because as a researcher, I am interested in how researchers behave, often constrained by the things that shape our behavior, but how we behave as researchers. So the subtext of this paper is really turning the lens on researchers and saying, why are you thinking this way? And we were doing that in part to also generate a framework that other researchers can use prospectively to say, okay, we have this innovation, or we are thinking about this. How can we reasonably map out the next 2, 3, 4, 5, 10, 15 years of what this might look like? How can we think about the potential obstacles and be very clear-eyed about what we may need to do with this system, again, L1, L2, L3, L4, to make sure this thing succeeds and play it out, right? And then think in terms of the strategies that we might use at different points, right? So the abide strategy is basically when everything works for you, right? That's the survivorship bias, for the innovation that you see in the pool every day that are still successful, often it's abide for them. That the 4 levels, L1, L2, L3, L4, are well aligned for them to enter and be successful, right? People see the need for it, the society loves the idea of it, the government regulation, etc. is very well set up for it. Insurers, professional societies, everybody thinks it's a great thing. The market is not too expensive. Everything's well set up. Scaled up. Now, that is rare. Although, again, as I said, we often don't feel like it's rare because we're often looking at the ones that are successful. And that when we're thinking of the ones that are not so successful, then we start to see that, or the ones that struggled, right, to make it. They really struggled. You see what the people who have tried to push it have had to do to make it successful. Okay. And one of the things that they may have to do is try to evade existing rules, right? Like trick the system or pretend that it is what it is not, right? And again, the kind of trick that I was talking about, if, for example, it had been thought of as a prescription pharmaceutical thing rather than a pill itself, right? It may have evaded a lot of the obstacles on its way, if that was how it was conceived, for example, right? Another strategy available is alter. So you can alter the existing rules, change rules, like, for example, putting it on the essential medicines list. Right? That's an alter kind of thing, right? You know that there's a structure somewhere that you need to go and mess with in order for this thing to work. And then you go and you sit, and that's what they did, right? They did brilliantly. They went and sat with WHO and kept advocating, kept publishing papers, kept taking it to them, found really highly influential people like former head of CDC, Tom Frieden, who has been actively promoting the Polypill at the WHO, those kind of things. Like keep pushing until you can change a rule, and then as you change that rule, other rules can then change beneath it, right? Mm-hmm. That kind of thing. And you can also exit. And exit could be you're exiting the innovation completely, or you're exiting the location where it's been difficult for you to thrive, right? So again, thinking about the options available to you when you are starting, thinking about the levels of institution or governance that you have to be playing with, we believe just gives you greater clarity about what you are trying to do. And that was the goal of this analysis, to turn the lens on researchers so that we can start to see ourselves a bit more clearly.
Thank you so much for elaborating. Actually, your explanation, I read the paper at least 3 times, but your explanation is actually shed more light on updated, let me say, upskill the language you're using, upskill my knowledge on the Polypill paper. The last
Yeah.
question, Professor, is I'm now putting you in a tough position, which is I want you to tell us your stand on this statement. The Polypill
Mm.
was criticized as an unnecessary over medicalization of a public health issue. What is your stand on this?
The active words there are unnecessary and over medicalization.
Yes,
If we say medicalization of a public health issue, it will be true.
exactly.
And I would even go as far as say that the over medicalization will be true largely. Right. Again, I think the spirit here is to go back to the earlier point that I was thinking about socioeconomic status and health outcome. I'm always suspicious of the tendency to look at poor people and say what they need is a technological thing or a drug without really sitting back to ask the question, the drug will solve one problem. This poor person has 100 problems. The problem the drug will solve is maybe number 57 on the list of that 100 problems. And that doing something that pushes that person up socioeconomically, right, will do 70 of the 100 things, like it will solve them. Like if push them all, right? And there's this dance in my head, and it's an uneasy dance for anyone who thinks about public health and global health in a serious way. There's this uneasy dance in my head all the time when I see us obsess over specific things like this, right? I know that it does something. It is not without effect. It does things. If this was scaled up, it saves lives. I know that. It does. But I also know, I'm also asking myself, if we were to invest that much energy into the other strategy, will we be significantly more successful? And I'm also asking myself, we've been trained to think doing something on poverty or something at the social level is too difficult. You won't be successful. It is not our job. We have all of these reasons why we don't touch that, right? But it would also be true that if there are people in the world who are powerful and know that their power and their wealth is dependent on the existence of poor people and their ability to oppress them, that is what they will be telling us to do. They will be telling us to look away from all that social things and just do this once. Because this ones also will make them richer, ultimately. At least a good number of them. Right? So it's a difficult thing to wrap your head around and function at the same time. They're almost two completely opposing things. So yes, is it over medicalization of public issue? Yes. Public health issue? Yes. Could the public health issue be solved in a different way, or in a way that perhaps is more social and more structural? Yes. Can I criticize those who are doing this for doing it? No. Right? I can't. It's what they find to do. There's a line in the Bible, I can't remember exactly how it's structured, but it's something like that which you find to do with your hands, do it well. I mean, yes, the best I can do is encourage them to make the most of what they are trying to do. Even recognizing that making the most of what they are trying to do also requires that they think structurally, and that's the logic of L1 to L4. right? That you have, the eyes have to be open to how this context of adoption and scale up of innovation is structured itself. You have to see it. Even if what brings you there is the little tiny thing that you care deeply about. So yes, I agree with the statement, but I agree in a kind, gentle, understanding, loving way.
Thank you so much, Prof, for elaborating so much on that. I feel you taking a stand, and also you took a stand. You took a stand, and you were not taking a stand. Something like that. Thank you so
Yeah.
much for honoring the invite and giving us some of your time, taking some time out of your hectic schedule to explain this and putting it, breaking down into nitty gritty for our audience to understand. Global Citizens, Dr. Fajembola's opinion is a platform where research meets understanding. And I believe Professor Abimbola has explained this extensively in a way that even when you outside the field of medicine, you outside the field of science can understand. And we looked at Professor Abimbola's paper, and if you've not read through the paper, as you've watched the video, please go through the paper, discuss with colleagues, especially if you're in the medical field. Discuss the cardiovascular polypill. There's a lot of discussion. When you read the paper, to me, I feel it's a bit political, and you have to yes to be able to understand it. So please discuss with colleagues, discuss with family members, and I believe with more discussions like this and with platforms like this, we can bring in more, we can make more policies to help patients and encourage health workers and the younger generation to make more adoptable forms of innovation, which and also encourage government to increase funding, especially on the cardiovascular polypill and other polypills in this generation. So thank you so much, Global Citizens, for joining us on this episode. And I don't know if Prof has any closing statement, so I should just send it.
Nothing, no. Okay, well now you've tempted me. My recommend my I want to say this to fellow researchers to think in more disciplined ways about the innovations we seek to promote the adoption and scale up. There are more disciplined ways to be more respectful of the people we're trying to be in service of, and more respectful of the systems within which they live, and more respectful of their realities. Just we can be better, promoters of innovation than we currently are.
Thank you so much, Prof. And also, it's not just about the money, it's not about the fame, it's about creating positive impact to impact the current and future generations of global citizens. So have a blessed week, everyone.